As a teenager, I was diagnosed with acute intermittent porphyria, or AIP, but my symptoms didn't present themselves for years. At 17, my first AIP attack left me unconscious and hospitalized, but with extensive treatment, I recovered from that severe attack. For me, having the right care, including knowledgeable doctors, and the right treatment has made all the difference. When I was 13 years old, my aunt was diagnosed with AIP. She had been sick with mysterious symptoms for a year before she got her diagnosis. Because AIP is inherited, it often runs in families. So all of my relatives on that side of the family had genetic testing, including me. I tested positive for AIP, but I did not show any signs or symptoms for 4 years. Some people may never show signs or symptoms, even if diagnosed. At the age of 17, I began to feel like I was unable to control my emotions, and I cried frequently. At one point, I began to feel pain in my abdomen that quickly grew worse. The pain became so bad that I blacked out. I was taken to the hospital, and because my family was already familiar with AIP, I was quickly able to be diagnosed and treated. The doctors first treated me with glucose, and when my symptoms did not improve, they recommended using panhematin. The doctors spoke with my family about the treatment and its possible risks, including the fact that it's made from human blood. Because of their experience with AIP, my family was familiar with panhematin, and we agreed that I should be treated with the infusions in the hospital. The therapy worked for me, and I regained full consciousness and continued to recover. Over the next few years, I gained back weight I had lost during the onset of my AIP symptoms. The worst symptom I experienced for a while was minor pain, and eventually even that faded. For the next 27 years, I was lucky enough not to experience any more AIP symptoms. Then, in 2010, I felt pain in my lower abdomen and the right side of my lower back. The pain spread, and I began to feel it in my arms and legs. My emotional symptoms also returned. Because my AIP hadn't affected me in so many years, my first thought was that I may have had ovarian cysts or another more common ailment. When my hematologist confirmed that it was an AIP attack that was causing my symptoms, I was treated with panhematin in the hospital again. Over the next 8 months, I received additional infusions for my AIP attacks, which occurred around my monthly menstrual cycles. Though AIP has certainly impacted my life, I was fortunate enough to have had an excellent support system at my job, which allowed me to continue working and made it easier on the days when I was not feeling my best. My family has also been impacted beyond just my aunts and my experiences with AIP. We help each other cope with the condition and have been involved with the AIP community to help support others with AIP. My 22-year-old has also been diagnosed with the condition, but has thankfully not shown symptoms yet. My family has always been there for me during my attacks and continues to be a strong part of my support system when I need them. Because of my family's history and understanding of AIP, I've been able to work with doctors who are knowledgeable about the condition and receive the right treatments quickly. Through my involvement with the AIP community, I've seen how the condition can impact others who struggle to receive a diagnosis and proper treatment. I urge anyone with AIP to be informed and find specialists who understand the illness. Answers and treatment are out there, and they can be an important part of getting through the difficult days and living with this condition.
Panhematin should only be used by doctors experienced in the management of porphyrias in hospitals where the recommended clinical and laboratory diagnostic and monitoring practices are available. Panhematin therapy should be considered after an appropriate period of alternate therapy, such as 400 grams of glucose per day for 1 to 2 days. Panhematin is not for patients known to be allergic to this drug. Panhematin is made from human blood and may contain infection-causing agents such as viruses and theoretically Creutzfeldt-Jakob disease. This risk is minimized by screening donors and inactivating certain viruses. Drugs such as estrogens, barbituric acid derivatives, steroid-like drugs, and blood thinners should be avoided during panhematin therapy. Doctors should monitor iron levels in the blood in patients receiving multiple courses of panhematin. Reversible kidney shutdown has occurred with high doses.